The U.S. spends a lot of money on healthcare. We've talked about this. We've also talked about how all that money doesn't get us better health outcomes. In fact, we rate pretty low on health outcomes when compared to other countries with similarly high incomes. One proposed explanation for this is that it's a result of low investment in social programs. That's the topic of this week's Healthcare Triage. There are data to support the idea that low social spending is hurting health outcomes. A 2009 study in JAMA found that housing and case management services for homeless adults with chronic illnesses resulted in fewer emergency department visits and fewer days spent in the hospital. Another JAMA study, also from 2009, found that providing housing for homeless adults with severe alcohol problems decreased health and criminal justice spending from over $4,000 per person per month to just under $1,500 after 6 months. This number decreased even further to under $1,000 monthly per person after a year of housing. At both points in time, there were significant savings compared to controls, even after factoring in the cost of housing. We've covered social determinants of health before, and we know they play a big role in improved health outcomes. If we spend less on the things that promote good health, it makes sense that we might pay for that on the back end with higher medical bills for sicker people. However, we don't actually have a lot of data from studies examining whether low social spending drives high healthcare spending in the United States. That is until a new study was published this August in Health Affairs. Using data from the Organization of Economic Cooperation and Development, or OECD, researchers asked the following questions. How much does the U.S. spend on social programs compared to other OECD countries? Do the data suggest that decreased social spending is associated with higher healthcare spending? And vice versa, is increased social spending associated with decreased healthcare spending? Researchers looked at 35 OECD countries between 1980 and 2015. This analysis of social spending took into account both public and private spending and excluded any spending not directly given to beneficiaries, such as administrative costs. They focused on social expenditures on factors that are known drivers of health. This included active labor market programs like welfare to work, disability and unemployment benefits, family programs, housing, pensions, and education programs. Healthcare spending included personal healthcare, public health and preventive health services, government, insurance, and out-of-pocket spending. The researchers also accounted for potential confounders like poverty, unemployment rates, and the proportion of the population that was elderly. The average GDP per capita across countries is approximately $41,200, with the U.S. coming in above average at about $56,700, because, we're rich. The countries spend an average of 17% GDP on social spending. The U.S. came in just under that at 16.1%. The country allocating the lowest percent of GDP to social spending was Mexico at 4.7%, and the country allocating the highest percent was Denmark, clocking in at 26.5%. Countries spent, on average, 8.8% of GDP in healthcare. There, the U.S. is an outlier, spending almost twice that at a whopping 16.8%. Overall, average social spending across countries increased during the period studied, which was largely attributable to spending on programs benefiting the elderly, which went from 4.8% in 1980 to 7% in 2015. Average spending on healthcare across countries followed the same trend, increasing from an average of 6.1% to 8.8%. Overall, the researchers found a significant positive correlation between the two expenditures, meaning countries that spent a lot on social services also spent a lot on healthcare, with the U.S. being a large outlier in healthcare spending. This correlation held when examining the rising cost of each expenditure over time. When looking at social programs individually, significant correlations were found for disability benefits, active labor market programs, pensions, and education. So to answer the initial questions posed by the researchers, U.S. spending on social programs is pretty average compared to other OECD countries. Decreased social spending was not associated with higher spending on healthcare. Increased social spending was not associated with lower spending on healthcare. This isn't quite what we would expect based on studies like those we mentioned at the beginning of the episode, but there are things we should take into consideration, especially given that this new study is observational. The authors point out that like-minded values may underlie the association, meaning placing high value on programs that benefit things like family and old age is consistent with placing high value on healthcare spending on those same things. They also point out that their study looks at data on a very large scale, which isn't great for picking up effects of specific social interventions or picking up effects in subpopulations such as the elderly or homeless. Another important consideration, mentioned in the article's press release, is that these two expenditures may not be substitutes for each other, meaning that maybe we shouldn't expect a decrease in one in response to an increase at the other, at least on a national level. So given that these particular data are telling us that social spending does not save us money in the long run, should we drastically reduce the amount of money we're spending on social programs? No! Healthcare costs are not the only potentially important outcome of social spending. Improving people's health is an established and very important outcome of this type of investment. For example, a study published in 2007 found that the Supplemental Nutrition Program for women, infants, and children was protective against preterm delivery, low birth weight, and fetal death, especially in women considered high risk. We also know that individuals who receive food stamps as children have better metabolic health scores in adulthood. And, as mentioned previously, housing and case management for chronically ill homeless adults reduces time spent in hospitals. And if you need further convincing, remember that social investments also have ripple effects that positively affect everything from the health of our economy to the health of subsequent generations, though improving current health and well-being in children and adults is important enough on its own. Sometimes good things cost money. We can't expect everything to also reduce spending. Hey, did you enjoy this episode? You should watch this whole playlist we've done on social determinants of health and how important they are in the United States and all over the world. We'd also like you to consider supporting the show at patreon.com. We'd especially like to acknowledge our research associate Joe Sevitz and our surgeon Admiral Salmon. The website to do that, patreon.com/healthcaretriage.